This week on the BackTable podcast.
Many women have no clue they're going through perimenopause. What they notice is that they can't fit in their clothes. Or they go to their primary care doctor and out of nowhere, they're pre-diabetic and they have high cholesterol. And so they're put on a statin, and this kind of came out of nowhere. So it's usually something like visible or something that they feel where they come into clinic. And then I look at their demographics and I go over their symptoms. And it's so obvious to me because now I know the questions to ask. But oftentimes they have no idea, because remember, perimenopause can start 2 to 10 years before your last menstrual period. So if you're in your late 30s, early 40s, you're in that prime time of perimenopause with erratic hormonal fluctuations.
This is Jose Silva as your host this week. We're happy to have two guests today. We have Dr. Amy Pearlman, you already know her. And we have her sister, her twin sister, Dr. Michelle Pearlman. She's a board-certified gastroenterologist and also co-founder of the Prime Institute. Welcome to BackTable.
Jose, it's so good to be here with you.
Thank you for having me.
So today we're going to discuss your collaboration, your unique approach into treating sexual medicine, metabolic health. But before we start, I want to share with this with you, ma'am. I have twin sisters. They're 1 year younger than me. They study together. They went to university together, college together, med school together. They practice together. So, but in your case, you guys went to med school different places, then did residency different places. At some point, you thought that you were gonna integrate your practice? Because when you're in residency, you're doing cystoscopy, one is doing colonoscopies, separate part of the bodies. But were you able? Did you know at some point you were gonna integrate your practice?
It was never our plan to start our own practice together. And we did undergrad together many years ago. We actually requested to live in different dorms so that we could meet our own friends. But my sister and I always came together to meet each other for breakfast. We would study at the library together. We didn't study the same thing. So I don't think we had a single class together in the 4 years that we were at the University of Miami. And then once we graduated, we were apart for about 15 years. And it was only once we were both at our respective academic institutions for about 4.5 years that we realized there was so much in our current healthcare system for which we were complaining on a regular basis. And we said, why don't we stop complaining about it and do something about it?
Yeah,
Good.
and I honestly can't remember, Dr. Amy, if it was your idea or mine. But I think one day, one of us must have said, why don't we just go in business together? Now, meanwhile, neither of us have any business experience whatsoever, but we knew that we were both really hard workers and we would figure out a way to make it work. But no, that was never in the grand scheme of things.
Good. So let's start, with asking, how do you two collaborate in your clinical practice?
It's interesting how our practice has evolved because we've now been in practice for about 2 years. And really, I would say for the first year or year and a half, we really had mostly separate practices. And we were trying to figure out how to display that on our website. My sister she's a gastroenterologist. She does sports nutrition, medical weight management. And then I did hormone optimization and sexual health. So they were very separate. Now, over the last, I would say 6 months or so, our secret sauce is truly in the synergy we have together. So we're actually rebranding our website to show and really display how much we are collaborating. And an example of that, our most successful patients are patients that see my sister because they're overweight or obese. They're also middle-aged. And so we're treating their hormones with systemic therapy, and we're also addressing their sexual health. So that's actually where we treat a lot of those similar patients.
Well, I think also we realize what we're good at and what is our individual niche and what maybe am I not an expert in. I can have actually very well-informed decisions now on hormone optimization and testosterone replacement in men, but I don't have enough experience where I would be the one that's actually doing that management. And so that's great. I will literally walk over to Dr. Amy's door, knock on her door, say, "Hey, Dr. Amy, do you have a few minutes? My patient wants to learn more about the nuances of testosterone." And so we can really have that hands-on approach and true in-person collaboration when the patient's there sitting in our office.
So it sort of happened organically, I mean, between the two population, the patient asking, and you offering both types of treatments.
I think really with our proximity, I mean, literally what my sister just described is she will knock on my door and say, "Can you please come to my office for a couple of minutes?" And she has 2 chairs in front of her desk. The patient's in one, I sit down in the other. My sister says, "Hey, John, do you mind if I talk to my sister a little bit about you?" And of course, John is thrilled that he gets that comprehensive approach. And really, all it takes is like a 5-minute little discussion there just to plant the seeds on the importance of hormone optimization. Next thing you know, he's walking out and scheduling an actual consultation with me.
Or with Dr. Amy, a patient will say, "Well, what are some good protein options?" Or "How can I improve my bladder health with nutrition?" So she'll take them into my little Prime pantry, show them a lot of the samples I have, and then again, have a discussion. I can go through what are some, 5 top protein recommendations I have on their way out. So it's all about providing those tools and not making people wait 3 to 4 months to get some of those, very clear answers.
Jose, I actually brought my sister in to assist me with a procedure. And I said, while you're assisting me, if you could please discuss sports nutrition and protein options with my patient.
What type of procedure was it?
A vasectomy. My sister almost fainted. I learned my lesson.
But at least the patient got
The patient did
information.
amazingly well
Yeah,
and got
yeah.
some really good information.
And he probably told his friends, "Hey, you need to go there." So is there a separate approach between men and women?
So that's where it's been really critical for my sister and I to really define what is my role and what is my sister's role. So I'll give you an example and I'll actually talk about the men and then I'll have my sister talk about the women. A lot of the guys are starting with me. So they're coming in because they're worried about fatigue, low libido, erectile dysfunction. They're curious if they have low testosterone. So I have that whole conversation with them. But obviously, as part of this conversation, first line therapy for any urologic condition that we treat is going to be lifestyle modification. The problem is, I don't know about you, but I was never taught how to discuss lifestyle modification with.
What is it? Yeah.
And we know that our patients need to eat better and exercise, but at what point did we actually learn how to sit down with a patient and in a very clear and concise manner tell them the types of foods and exercise they should be doing in a way, most importantly, that encourages behavioral change? We really never had that type of education. And so I'll kind of plant the seeds and I'll talk about the importance of nutrition. And I have great handouts to give. But I say to my patients, again, I stay in my lane. For really nuanced discussion, I would recommend you see my sister. And let me tell you about some of those further discussions that you can have with her. In addition, my sister has a Seika bioimpedance scale. So as much as these days, we don't have to guess, we can actually get really good objective information. Sure, I could get my patient on the Seika scale, but I don't have the background and the expertise to actually walk through all the different metrics it provides. So I offer them, if they want to get on the scale, to understand their visceral adiposity, their skeletal muscle mass.
Amy, you're stealing my thunder.
I'm stealing your thunder. And perhaps most importantly, what to do about it. That's why you need to see my sister. So then they'll go to see my sister for a more nutritional and exercise management plan.
So, Michelle, you have your background in weight management. Did that happen during residency, or it started after that you became engaged in this?
Yeah, so that was also actually never my plan. Now, since the beginning of time, I was always interested in nutrition, exercise, really for myself. I was, a bodybuilder. I used to compete kind of on and off, and I was fascinated by it. One of the reasons why I went into the field of gastroenterology is because I thought that as a gastroenterologist, we're doctors of the intestine and the gut. We must learn something about nutrition. Boy, was I wrong. We are trained in how to do colonoscopies, right? I have a scope here in my office. So we are trained just as urologists are trained as surgeons, gastroenterologists are trained as proceduralists. And so a lot of our training and the exciting things that we see are doing procedures, endoscopy, colonoscopies, liver biopsies, etc. So it actually wasn't until my 14th year of medical training or my 3rd year of fellowship that I actually sought mentorship outside of my fellowship training program and was mentored by an endocrinologist who started the weight management program at UT Southwestern. And he is the one who changed my career. That was the first time I ever learned how to sit down with a patient, understand what are their goals, how do they define success, what does their family unit look like, what do they like to eat, what do they don't like to eat, teach them about the foundation of nutrition and exercise, and then start the discussion on potential pharmacotherapies to help them reach their success. My 14th year of medical training as an endocrinology, fellowship, which I didn't do, right? But that's really what garnered my interest. I was actually told by one of the faculty, one of the attendings, that nutrition was not a good career path, that it would be much easier to just be a gastroenterologist and do endoscopies and treat heartburn. And my goodness, if he could see my clinic today, there's such a gap in the market when it comes to these things, these very mundane, basic things. The reality is, in the typical healthcare scenario, time is so critical. But yet, as we advance more and more in technology and knowledge, we get less and less of it. But to have these nuanced conversations, it doesn't matter how smart you are or how fancy your clinic is. We need time to have these nuanced nutrition discussions.
Now, like you mentioned, I mean, sometimes the patient, I tell, hey, you need to lose weight, you need to eat better, but they need a routine. It's not just, hey, go and eat better. I mean, if they're 8 hours, 10 hours in a truck driving, how they can eat well? I mean, there's no way unless they start doing their own packing of food, preparing their own food, because they're going to just find fast foods around.
I do want to ask, I want to bring up a question here, because even a simple question that I get asked very often, which is, Doc, how many grams of protein should I eat in a day? So for the, urologist listening to this call, Dr. Michelle, like if a patient asked anyone listening that question, maybe you could provide a few bullet points on what that person might tell that patient.
Yeah, I think it really depends on what guidelines you're looking at. A lot of the guidelines out there by the ADA are very outdated, where we're telling people they need, let's say, 0.8 grams of protein per kilogram of body weight, which is actually not that much. I recommend actually higher. So, a lot of people measure themselves, let's say, in pounds. Now, it depends on where someone's starting with as far as how much muscle they have, if they're trying to just maintain muscle or gain muscle. But for a lot of patients, I'm telling them we should really aim for, around a gram of protein per pound of like ideal body weight. Okay. So let's say you have a 180-pound man that really their ideal body weight is 160, then probably 160 grams of protein. But again, it's going to be highly variable. And the biggest thing here is it's all about the trends. So if I tell, let's say, a perimenopausal woman, okay, you need 100 grams of protein a day, and she's busting her butt in the gym and hitting 100, but still losing muscle, then I'll say, okay, you are consistent with 100, maybe you need 120. We have to follow the trends because everyone is very different.
So you mentioned perimenopause and menopause. Can you go into details? What led you to start treating them?
That's also a fascinating story. That was also never in the plan. Our practice manager who we consult with had actually recommended it probably 1 or 2 years ago and said there's a huge market you all should really learn about female hormones, because Amy was doing it for men. And, and I didn't know enough about it until I really started listening to the struggles of every single woman that walks into my clinic. Most of my patients are middle-aged, ranging from, 40s to 60s. What were they telling me? All of a sudden, doc, I've gained 20 pounds and it all went to my gut. I don't feel like myself. I'm having brain fog, anxiety, poor sleep, frozen shoulder, plantar fasciitis. I'm bloated, right? Pain with sex, urinary tract infections. I can get anyone to lose weight with these GLP-1 medications, and a right nutrition approach and exercise. People will lose weight, but I wasn't targeting all these other important quality of life, factors that matter to women.
Well, Michelle, you thought they were side effects of the GLP-1s.
Yeah, I mean, they were complaining of hair loss, right, and fatigue. So I thought, okay, maybe they're not getting enough protein. Maybe, that's part of the issue. And then I looked back and I said, you know what? They're all freaking perimenopausal. And so if I'm not treating the underlying hormonal deficiencies, then I wasn't, really optimizing their health. And we saw the success in the mutual patients with my sister and I. They were men with low testosterone and they were struggling to lose weight. And when we optimized their hormones and put them on GLP-1s or whatever medications, or even just optimizing their hormones, but put them on a good nutrition exercise plan, those were the men that flourished. And so Amy said to me one day, why can't we do this for women? We absolutely can.
But so we didn't know how to do it. So I know you've had Dr. Rachel Rubin on this podcast before, and I had been texting her and I was asking, Dr. Rubin, when are you going to offer that course? When are you going to offer that course? I really want to take it, because she had been contemplating offering a course to teach healthcare providers how to treat menopausal symptoms for a while. And then she said, I'm going to be offering the course. And my sister and I think were two of the first people to sign up for it. So that's what I encourage people listening. If you're, let's say, in training, most of what we learn in training might have nothing to do with what we actually do in our careers. There's so much that we can learn outside of our training, and we just have to identify, what do I want to learn? Who's an expert? Will they teach me? And then you have them teach you. And that course was one of the, I think, career-defining events in the early careers of my sister and I. Because just like my sister, I wasn't treating women. I had a clinic full of men for years. I was a men's health specialist, and now I'm treating women. And Jose, I didn't think I could help women. Isn't that crazy? I'm a woman. I did not think I could help women. I didn't think there were as many tools in the toolbox that I have for men.
And it's funny. I mean, for a man, we've been treating testosterone for a long time, but in women, you're doomed. Those are your expected symptoms. You have to deal with them. But thankful for you guys. I mean, now things are changing, and you don't need to feel depressed. The hair loss, all the things that you have been mentioning.
Well, I think I was listening to Dr. Kelly Casperson, and she made some comment like, all the urologists out there are giving out, tons and tons of Viagra and Cialis. But who's treating the women? Who is treating their partners? Because you can have, an amazing erection and, amazing libido, but if their partner wants nothing to do with it, and Dr. Amy saw this firsthand in her clinic. Dr. Amy, what were your male patients asking you?
My male patients who were given testosterone for their low T and they were on their daily Cialis, love that medication. That's like the cocktail, right? You get a patient on some low testosterone therapy and Cialis, and they are doing amazingly well. And Jose, they would ask me, can you help my spouse? And I would tell them, it's out of my expertise. I can't help your wife, but let me see if I can find someone who can. And we actually found some really good providers in the South Florida area, but they were really busy. And so their wives never got in to see them for help. And so these guys kept asking me. And at some point I said, you know what? I don't know how to do it right now, but I'm going to learn. And again, it was like around the same time that I was taking Dr. Rubin's course, and now I have the skills. And so now I treat women. But when I saw one of my early female patients, she said to me, and I don't think I'll ever forget this, she said, Amy, I love my husband and I have an incredible relationship with my husband. I just don't know why I don't want to have sex with my husband. And now he's annoying me because he feels great. He wants to have sex. He tells me he's so attracted to me, he can't keep his hands off. And we got into it because that's annoying. And I told her, well, your husband is a little bit annoying, so I don't take full responsibility for that. But I said, but I do take partial responsibility. You're right. When two people have low libidos, who cares? No one cares. But you help one person and the other person's libido is low, and I'm potentially worsening relationships. So why don't we delve into, Michelle, do you want to talk about how your role in the female patient, and then I'll talk a little bit about my role?
Yeah. So usually the women patients will see me first, and we go over the gamut of literally, the 70 symptoms that can affect women. So I'm trying to get a baseline of what sort of struggles they're dealing with.
Are these women going for for perimenopause symptoms or for weight loss? And then you dive into the other part.
Yeah. So many women have no clue they're going through perimenopause. What they notice is that they can't fit in their clothes, Or they go to their primary care doctor and out of nowhere, they're pre-diabetic and they have high cholesterol. And so they're put on a statin, and this kind of came out of nowhere. So it's usually something like visible or something that they feel where they come into clinic. And then I look at their demographics and I go over their symptoms. And it's so obvious to me because now I know the questions to ask. But oftentimes they have no idea because remember, perimenopause can start 2 to 10 years before your last menstrual period. So if you're in your late 30s, early 40s, you're in that prime time of perimenopause with erratic hormonal fluctuations. Also nowadays, when women have IUDs or they've had, let's say, ablations to their uterus, they don't have their period. So many of them have already gone through menopause and have no idea because they don't have their typical menstrual cycles. So usually it's the weight that brings them into my clinic, and then I delve into that hormonal piece. But now that we are, revamping our website and doing more branding, we are getting people specifically coming in for hormonal optimization who don't need to lose weight, but want to understand also how to incorporate nutritional strategies and exercise to help optimize their health. Really what Dr. Amy and I look at is frailty, which I also was never taught in any of my training because I never had ways to assess muscle mass or frailty. I can see in real time what someone's muscle mass is. And now in every woman coming into my clinic who's in their 40s, I'm ordering bone density scans because I see what happens when we don't take estrogen deficiency seriously. I see what happens now that it's death by Zoom, we're leading sedentary lifestyles, we're not eating enough protein, and by our mid 40s, we now have osteoporosis of the lumbar spine. So I'm looking under the hood. Someone doesn't have symptoms of osteopenia or osteoporosis, but if someone does, then I really get into the hormone discussion to say, okay, you have osteopenia, you're 45. Even though you're not having the typical hot flashes and night sweats, we need to protect the bone. So let's talk about hormones. You may decide you're not interested, totally fine. And if you're not, we also need to talk about, proper calcium and how to get it from your diet. How do we supplement with vitamin D? How do we do jump training? So I also do exercise programming and then work with local physical therapists and personal trainers to make sure people are doing the appropriate exercises. We need to stop telling older women and men to go lighter on the weights and higher in the reps. We actually need more weight, more load to have adequate muscle stimulation. So if you hear podcasts from Dr. Stacy Sims or Dr. Vonda Wright, an orthopedic surgeon, they are all about muscle as medicine and they have incredible content to share.
And then my sister, bless her, will ask her patients, how's your libido? And we had a recent patient that said, what's libido? And she was like, you need to see my sister.
And I asked them about the genitourinary syndrome of menopause, pain with sex, vaginal dryness, urinary tract infections. And if those are, issues for them, I tell them systemic hormones are not great treatment options. I think it would be valuable for you to sit down with my sister and talk about more topical therapies that would help you in that regard. But every nursing home woman should have vaginal estrogen. And Dr. Rachel Rubin talks a lot about that. We're so used to and trained to give antibiotics, but we need to learn how to treat the local tissue as well.
So my sister and I, we have very defined roles. As you can see, I'm treating men with systemic hormone therapy, and I'm treating women with local vaginal therapy versus my sister who's treating a lot of the cardiometabolic and systemic parts for the men. And she's treating the systemic hormone therapy for women. So we combine our expertise, but it's also very defined and separate.
Why has the systemic replacement therapy, hormone replacement therapy in women have been sort of like a taboo? I mean, there's sort of, even talking to GYNs, no, they're going to have a blood clot. I mean, how accurate is that?
It's fascinating because all my patients have gynecologists, and we have some amazing gynecologists down here in South Florida. And I'm a gastroenterologist, right? So that it was never in my plan, but I just listened to my patients and they were desperate for help. And I had to figure out how I was going to provide that service. But it really came out with a Women's Health Initiative study that, came out over 2 decades ago. It's taken 20 years, thank goodness, actually, to social media and just leaders in the field like Dr. Mary Claire Haver, Dr. Rachel Rubin, Dr. Kelly Casperson, who are really fighting for change in the way that we treat women. It's really paramount. One, there's just not a lot of research, but that study that came out, basically they were using synthetic hormones, they were using oral estrogen, and they were doing it in an older population because they wanted to see cardiovascular outcomes. So you're not going to, enroll patients who are 40 years old looking for a cardiovascular outcome. And the way they reported the study is they said, 4 out of 1,000 women developed breast cancer on placebo, and 5 out of 1,000 women developed breast cancer on hormone replacement therapy. So they said it was a 25% relative risk increase. Very well, maybe so. But if you actually looked at the absolute risk increase, it was minuscule. It was insignificant. It was nothing that the press and media should ever highlighted, but they did. And so it's taken 20 years for us to actually look at that data and say, wait a second, they were older individuals. They were enrolling people upwards of 79 years old. You can't prevent heart attacks and clots when you're 79 years old. We're using bioidentical hormones, so not the stuff that we used to use back then. We're using a lot of transdermal approaches like the estradiol patch, which doesn't go through the liver, does not increase risk of clots. So times have changed. Medications have changed. Our approach has changed. People are living longer. 100, 200 years ago, many people maybe didn't, live past the age of 50 or 60. Now we are. A third of our life is spent post-menopause, and we need to take that seriously.
Jose, do you see the passion of my sister, a gastroenterologist, talking about it? It gives me goosebumps. But I don't think, just like it was never in our cards to have a practice together, who would have thought that my sister, a gastroenterologist, would be a female hormone specialist? I love it.
No, but right now, that's the type of medicine we should be practicing. Everybody should be talking about that to the patient. That's the reality of our practice. We're just treating the symptoms rather than treating before everything happens. So,
but I think the reality too is that a lot of people, and I imagine a lot of people listening to this podcast, are really busy. Whether it's treating kidney stones, BPH, like a lot of people are really busy. And even if they might have interest, or even if they know that people deserve these conversations, they just may not have the time to have it. And that's where I think my sister and I have learned the power of connecting our patients to the leaders in female sexual and hormonal medicine. I have no problem telling my patients, that is out of my area of expertise, but why don't you pull out your phone right now? I want you to follow this person right now on Instagram. I want you to subscribe to this channel right now on YouTube, and I want you to inform yourself of this topic that I don't have expertise in. And I think that is just as fine of an exit strategy. But I think we need to have that exit strategy to give to our patients, and sometimes that's going to be good enough.
What have you learned so far from seeing the weight loss patient after starting testosterone therapy? Are they getting better faster, or is a slow road for success?
Yeah, I think the biggest thing is we always need to, pick the appropriate candidates for hormone optimization. If you have, let's say, a gentleman who is, smoking, drinking, not sleeping, going to club space here in Miami until 3 a.m., is testosterone going to change his life? No. Is a medication like, Wegovy or Zepbound going to get him to lose 30 pounds and live longer and protect his heart? No, not if he's living that lifestyle. Really, the way our practice is, we are really targeting people who are ready to invest in their health and invest in their wellness. And we as physicians are investing our time into really optimizing their life and their health, not just 6 months from now, but 6 decades from now. So it's really an investment from everyone involved in the health of that patient, both on the provider side and the patient side. So it's really figuring out who is the right candidate, making sure we're not hurting someone, for instance, in Dr. Amy's case with future fertility. In my case, my gastroenterology background is extremely powerful because most of the side effects of these GLP-1 medications are gastrointestinal related: nausea, bloating, heartburn, diarrhea, constipation. So it is in my wheelhouse to say, okay, you're having diarrhea. It's probably, that we just started something like Ozempic. Let's go back to the drawing board. What dose are you on? How fast do we titrate it? What did you eat the night before, right? Because it's actually, nutrition's very complicated with these GLP-1 medications. Maybe it had nothing to do with what you ate, but the mere fact you just did your injection and then you ate dinner at 10 o'clock that night. Even though it was super healthy, you ate way too late on the first day of your injection. very nuanced conversations. So my background understanding proper digestion and absorption and how these medications work is very, very important. And then for diagnostic studies that I don't do, I have a referral network. So I have a guy down the street. He's a phenomenal gastroenterologist. Anyone who needs diagnostic, let's say fibro scans or endoscopies or colonoscopies, I send him their way.
Dr. Michelle, can you talk a little bit about the patients that you see that you put on a GLP-1 medication and they're losing weight? Maybe you can talk about what you're seeing in terms of their muscle mass as they're losing weight, and then we know exactly when they see me.
So, Jose, not sure how much you know about GLP-1s, but, what I think we typically focus on and what the studies look at is total weight loss, right? That's what everyone's talking about. Okay, Wegovy has, 17% mean body weight loss. Great. Those numbers are fantastic. But in only a small cohort are we actually looking at, is that muscle, lean tissue, or is that fat? I'm able to track that in real time. So I have the Seika bioimpedance scale where I get patients in on a monthly basis to actually track that. That's how I can make decisions, clinical decisions on how to titrate the medication. Are they actually getting enough protein? What sort of resistance training are they doing? And how can we optimize those? So my patients will sometimes get frustrated with me because they'll come in and say, Doc, the medication stopped working. I only lost 2 pounds this month. And I look at their metrics and I say, okay, you lost 2 pounds, but you lost 2 inches in your waist circumference. Your visceral fat went down. You gained 2 pounds of muscle, right? That's what we care about, in a long term, basically, and improving cardiometabolic health. So I don't focus so much on total weight loss. I want to know, where is that weight loss coming from to really, maximize, again, long-term success, which is a different approach from really all these virtual clinics. It's become weight loss commerce, just writing the script. That, Jose, is the easiest part about my job.
So Michelle, so for that patient that wants the miracle drug, just the injection and expect miracles, is that accurate? I mean, the medication won't give you muscle mass, right?
Absolutely not. Now, the medications don't cause bone loss or muscle loss. The reality is that when we lower your appetite, oftentimes people will have a piece of bread and they're not prioritizing their protein. Or they're losing weight and they say, oh, okay, I'm losing weight. I don't need to go to the gym. Or I'll start lifting weights once I get to my goal weight. That's the worst thing you could do. You want to minimize muscle loss from day one. That is critical. So those are all things, that I keep in mind. But it's really less so, how do I lose weight? What I tell people is, I want you to keep asking yourself, how do I maintain or gain muscle? Because the medication will help you lose weight, but it's not going to help you maintain or gain muscle. You have to have adequate protein and you have to stimulate the muscle on a consistent basis. These medications are not cures. Metformin is not a cure for diabetes. They are tools to kind of sensitize your body to insulin. These medications are tools in the toolbox, just like the ones that Amy has in her office with the vacuum pump and cock rings or whatever. These are tools in the toolbox.
Another thing that warms my heart to hear my sister say.
Which I never knew what those were until I saw them in her office. These are tools in the toolbox to make the process of losing weight and improving cardiometabolic health a little bit less painful and a little bit easier. I did not say easy and I did not say painless.
And Amy, for us, I mean, as a urologist, we're taught how to replace hormone. But you have mentioned a couple of times optimization. Is there a difference?
Yeah, I think there is a difference. And that's where I use the guidelines and I use the research to help inform my decision, but I don't rely on them for every decision that I make. And I don't always play by the rules. And I want to explain that a little bit. Because a lot of the patients, or pretty much all the patients that my sister refers to me, are patients that they're losing weight, but they're either plateauing in terms of their muscle mass or they're losing muscle as they're losing weight, despite the fact that these patients are spending an astronomical amount of money on personal training. And they are eating their protein and they're reducing their alcohol and they're really putting in the effort, but they are still having trouble gaining lean muscle mass. So even if these guys have a low normal testosterone or even a testosterone level, like let's say in the 400 range, and I'm always checking their free testosterone as well, when they come to me, their goal is, when I say, what are your goals for today? They say, I want to gain muscle. Now, Jose, if that patient showed up in most healthcare providers' offices using our standard, American healthcare system guidance, we would say, eat less and move more. I love when my patients come in and say, I want to gain lean muscle mass. That is what I think it was Dr. Mary Claire Haver that says a nursing home prevention program. If I can help these patients gain muscle, I will keep them out of the nursing home longer. I recently went to a conference and there was an incredible talk talking about frailty in the urologic patient. And it was talking about how we have to sort of reconsider some of these medications that we use for overactive bladder and other conditions that we regularly treat, considering the frail patient. I look at it as, what is my role when I'm seeing this person in my office and he's 45 years old? How do I prevent him from getting frail so I don't have to worry about his frailty at the age of 85? That's really the practice of medicine that my sister and I are in. So I'm not afraid of treating someone who has a testosterone in the 400s. Because like my sister said, I ask myself, how can I hurt this person? And in all honesty, how can I hurt this person? And I just use what research has told me, and I ask them about their fertility, and I define that. And then for a lot of these guys, I'm optimizing their hormones. And you know what we see? We see the most beautiful thing. And as we say, a picture is worth 1,000 words. And in this sense, I always look at my sister's Sacred bioimpedance reading. It's like one of the most important factors I look at before I see one of my patients. And I see that their muscle mass is now going up. And I can pinpoint on that graph exactly when they started testosterone. And that's a beautiful thing. It's a beautiful picture for me to see.
And the reality is, these are not people who want to start strutting a stage to be bodybuilders and have necks out to here, that typical roided out appearance. These are the movers and shakers of South Florida who are, businessmen who live very productive lives and want to continue supporting their family and feel good when they wake up in the morning. But there is still such a stigma when it comes to optimizing hormones in both men and women and wanting to look and feel great naked. Why is that a stigma today?
Exactly. And Amy, what's your go-to testosterone? In case, is it different from replacement to optimization, what you give to the patient?
No, it's really the same options. I'm a big proponent of, one of the oldest medications that's still incredibly common worldwide, which is testosterone cypionate. And then I also use one of the oral medications, Kysotrex, which was FDA approved about 2 years ago at this point. And what's really nice about using the data that my sister collects with the muscle mass is sometimes on testosterone, depending on the dose, patients may not come into the office and tell me, I feel amazing. And this is how, we love when those patients come in. I know it's a good day when I have a low T patient coming in, but sometimes it's a little bit more subtle. And so for the patients that I share with my sister, because their marker of success is not necessarily erectile function or libido, their marker of success is muscle mass. So what do? I track your muscle mass. And so for the guys that some people might say did not benefit with testosterone therapy, if they're gaining lean muscle mass on her scale, they are benefiting from testosterone therapy. It's just in most clinics, we're not tracking that relevant factor.
And that patient that is you're treating for testosterone alone, that is lean, good muscle mass, but is still feeling a little bit tired once more, at some point, do you send that patient to your sister, to Michelle?
I have a very basic conversation about nutrition with my patients. And this is where, because there are a lot of people that are listening who may not have someone in their back pocket like I do with my sister. I'm very lucky and I acknowledge that. And so that's where I've created shared material that my sister and I put together, right, as a collaborative effort that gives recommendations on healthy, high protein options and ways to get what are the differences between the different, whey protein and other things that you might put in a protein shake. And so for people who don't have the ability to have someone like my sister, that's an opportunity to maybe just co-create something with one of your colleagues that might be able to add that expertise. So I have, most of my patients are not patients that I send to my sister. But Jose, every single one of my patient gets a primer on nutrition. And I just tell them, I say, look, I'm not going to go through every page here, but nutrition and exercise are the foundations for everything we're discussing today. And I want you to read this packet when you go home. But at the very core, as much as we can eat a whole food, plant-based nutrition plan, that is going to be optimal to optimize our hormone health, our sexual health, and our urinary health. And sometimes that conversation takes all of 30 seconds. Like, I think everyone can actually fit that in. And I guess the exit strategy in that case is just to give someone a packet and say, and I'm going to have you read this at home. And just like with the hormone conversation, if it's out of our expertise, I also see it as I am doing my job, even if I just introduce an educational packet and give it to my patients. Again, sometimes that is good enough.
Well, I think also with just synergies, I was going to say like gut health and pelvic floor health. So as much as I'm a gastroenterologist and Amy is a urologist, all these organs are in the pelvis. So if someone has urinary issues, they often have defecatory issues like either fecal incontinence or constipation. So the nutrition, the movement, the hydration is really important, really for all of those issues. So we work also with pelvic floor physical therapists, and really optimizing nutrition to improve gut health. Our gut is our largest immune organ. The last thing I was going to say about the Seika bioimpedance scale is I will often actually tell Amy, hey, Amy, I think you need to check this gentleman's estradiol level maybe sooner than you'd think, because I can actually tell that they're retaining water on my scale. And so oftentimes we'll check it, their estradiol's up, and then she actually will need to either modify the testosterone dose or maybe give them a small dose of an estrogen blocker. So having, we can't track what we don't measure, whether it's my scale or wearable devices like the Oura Ring to track sleep and how nutrition impacts that, or alcohol. We need to harness technology because the reality is we're not getting these metrics in most clinics, but most patients have technology. We need to use these wearable devices to become better informed as physicians, to give people information that is much better than just getting them on a random scale at a random time when they're stuck in Miami traffic. Of course, their blood pressure is going to be high. We have a blood pressure cup just in case something happens during a procedure. Do you know the number of times I've used it on a patient? 0. Okay, I don't even know where it is right now. Because what's the point? My patients check their blood pressure at home. That is much more valuable than me checking it here in clinic unless something's up.
The last time you saw the blood pressure was when you saw the vasectomy.
And that was the blood pressure cuff on myself before I
Exactly.
almost passed out.
So Michelle, Amy mentions plant-based protein. Can you give us just a crash course in animal protein versus plant-based?
Oh my goodness, loaded question. Okay,
But a
protein.
small.
I know.
That should
Protein
be
consists.
an entire episode.
Protein has amino acids that are essential for life. We as humans, if you look at the macronutrients, fat, protein, carbs, we need protein to survive. We won't survive without it. We can survive without carbs and fat, although it may, it's not optimal for overall health. So there are different types of protein. We have animal protein, and we have plant-based protein. So animal-based protein, a lot of the things that we see would be something like a whey protein or a casein. You'll see those in a lot of protein powders. Or, protein, obviously, that we get from, collagen that's great for the skin, hair, and nails. All of these things are in food: chicken, fish, steak, all, eggs, milk, all that good stuff. So protein is really critical. Then we have plant-based protein options. So you have healthy plant-based protein options, not so healthy ones. The healthy ones would be things that you can identify if you were to see them. Edamame, chickpeas, beans, legumes, nuts, seeds. They all have a great combination of fiber and protein. So you really get, a 2-for-1 here. You get fiber, which is incredibly important for gut health, and you get protein, which is really important. Now, specifically as we get older, we need higher levels of leucine. Leucine, you're going to get more so from your animal protein products. You can still get it from plant-based products, but you need to eat a much larger amount. But a combination of both is really important. But it's really the unprocessed one. So if you get like a Quest protein powder where you're getting your leucine, you're getting your whey-based protein, but you're also getting 50 other ingredients and artificial sweeteners, not ideal. You want to choose one that has minimal ingredients. In general, we should try to get our protein from food that we can identify. If there's a nutrition label with 5 or more ingredients, it is ultra processed. If we can't get it from food, then using supplements, credible supplements with minimal ingredients like powders can be helpful, but getting it from food is really optimal.
And Amy, how about you answer the same question to the patients, or you just send the patient to Michelle?
Well, no, I will actually, I think it takes my patients aback a little bit because I'll say, walk me through a typical day of eating. And usually they'll say, oh, I eat pretty healthy. I'm like, okay, what do you eat for breakfast? Because they're not expecting to
Yeah.
have this conversation with their urologist. And then they'll kind of go through what they eat for breakfast. And I'm like, okay, then what do you eat after breakfast? And we go through a typical day and I write it down in my note. And I do the same thing when it comes to exercise. And I say, how many days a week do you exercise? And they might say, 3 or 4, but it doesn't end there. I say, okay, what do you do for aerobic exercise? And what do you do for resistance training? And I find that a lot of my patients, they walk and they do some aerobic exercise. A lot of them do not do resistance training. So I give them a little bit of that primer. And I say, you have to do resistance training. This is why, because I can have you on testosterone. Yes, you might gain a little bit of muscle, but you're not going to really optimize your gains unless you stimulate the muscle. I might show them a few quick exercises to do, but I'm not going into the details. If they want to know more of those details, I'll send them to my sister. But I will send them home with a gift bag of healthy protein options. So we have a snack room in our office and a lounge area, and these are snacks that my sister has curated. And so I will say, again, this is one of those exit strategies. I'm not going to a 1-hour conversation. I'm simply saying, based on what you're telling me you're eating, I think you need to eat more protein in your day. So why don't you try these healthy snacks? We got some edamame here. We have some snack pack of almonds. We have beans in a bag. I know it sounds crazy, but they are divine, right? And so
Beans
that's
in a bag.
beans in a bag. And I send them home with the gift bag. And then my sister, I don't know if Michelle, if you want to mention this, she has an online platform where she has all these curated snacks. So it's another great exit strategy for me to say to someone, why don't you scan this QR code and you can learn about all the healthy snacks that are extremely convenient and cost effective. And my sister already did the work.
That's awesome what you guys are doing. And Michelle, you've been doing this for a few years now, or the integration, because you mentioned before at the beginning, has been for the past 6 months, the integration, but you've been doing the nutrition aspect of since you started your
Yeah, I
practice.
mean, even when I was in fellowship training, I actually created my own little nutrition clinic that didn't
Wow.
exist, but I kind of tried to target those patients. My attendings had no clue what the hell I was doing because they had no expertise. So I was kind of teaching them, which was a lot of fun. I was faculty at the University of Miami and actually started their medical weight management program, which I was the only one that actually did that. So that was a great experience. You kind of learn what a lean team looks like on how many resources you need to actually do it. And I learned it actually wasn't that many people. It was just you needed more time, which I didn't have. It didn't matter how many resources I had. If I only had 20 minutes to see a new patient and I wouldn't be able to see them for 6 months for follow-up, there was no way I was going to develop a successful program. Nothing against my prior job. That is the reality of all healthcare systems. Insurance does not pay for you to sit in front of a doctor for an hour and a half. That will never happen. It will never happen. So Amy and I created this on our own where we could actually, create that time for our patients. So yeah, it just requires a lot of time. But I knew what worked. I knew what wasn't working. And my sister and I just said, okay, we can really create something special. We just need to listen to what our patients need. And the cool thing is about starting our own practice is we pivot in real time. We find out what works. We find out what doesn't. We get feedback from patients. And then we expand or we get rid of, service lines. And that's a really exciting thing. We can implement technology, innovation, education, outreach, research in real time, collaborate with, the leaders in the field and practice medicine the way we think it should be done and what evidence supports.
Man, you guys are out there. You're putting videos of exercising, eating right. So you guys are
Dancing,
doing
you
it.
forgot our dancing videos, which gets
Dancing
more
also.
hits than our actual
Yeah.
content.
Yeah. So walk us through what do you guys eat in a day? I mean, more or less the same each other, or you guys have different diets?
Oh, Michelle, why don't you walk through what you eat in a day?
Oh, what do I eat in a day?
Yeah.
I usually don't tell people because what I do is probably not realistic for most. But okay, how do I start my day? I'm up at 4 a.m. and I actually like do my laundry. I'll actually prep food for the day.
What do you do on the walking treadmill?
Oh, yes. Okay. So I'm all about bone health. So I put on my weighted vest. I put on my sneakers. I'm still in my pajamas. I get on my walking pad and I brush my teeth for 10 minutes. But I
On
get
the walking pad.
on the walking pad, but I get 2,000 steps in before 5 a.m. Then I head to the gym, get about an hour and a half workout. As I'm leaving, Amy is coming. I always check with the front desk and say, hey, have you seen my sister yet? Get ready, head to the office, but always start my day off with probably 40 to 50 grams of protein. We're learning more and more the importance of that, especially in peri and postmenopausal women. We're so used to doing things like intermittent fasting or really staving off, until we're super hungry. But actually that drives up our cortisol levels. So we really need to be starting our day off with, 40 or so grams of protein. And then I meal prep every day. I bring my rice, cauliflower, butternut squash, either ground turkey, fish, tofu, edamame. Amy will often go to Publix and bring me some Greek yogurt and fresh big blueberries. So we always keep healthy food in the office. Our goal, not just for Amy and I, but also our staff, we have one administrative assistant, is to make healthy food accessible and the garbage very, very inconvenient. So not only do we preach that to our patients, we truly practice that as well to really be role models. But yeah, protein, fiber, you can identify all the food and really try to limit the ultra-processed food. And then really try not to eat too late. I've noticed using wearable devices like the Oura Ring, eating late for me, even if it's super healthy, has a huge impact on the quality of my sleep. And my day starts the night before. Sleep is so incredibly important.
And we only keep healthy options in our office because if we kept unhealthy options, I would eat it. And I believe that food is the foundation for medicine, but if it's convenient, then who can turn down a cookie? So we just don't allow that stuff in our office. So I will snack on edamame and lentils all day.
No pizza Fridays. You mentioned, most of the patients that come for the low testosterone in the office, they're always asking, what can I do to boost my testosterone with food? You already mentioned a lot of it, the proteins, stay away from processed food, the fatty food. Anything specific that you would tell someone?
I tell my patients it's as simple or as complex as we want it to be. But really, the nice thing about the guidance that I'm going to provide is that the recommendations for optimizing brain health are the same for heart health, are the same for gut health, genitourinary health, and hormone health. Like, could we make it any easier, right? And so I really just emphasize as much whole food, plant-based, nuts, seeds, fruits and veggies. Like, that's literally what I say. And it literally takes 30 seconds and I give them a packet. And then we move on to the next topic. But every patient hears me give that spiel. And sometimes I think that's good enough to say for the most part.
But Amy, what about your thing on watermelon? What if watermelon was the secret?
The other thing too is I really do encourage my patients to be their own experiment, and if there was a study that figured out what are the top 5 foods to improve erectile function. But what if it was watermelon and sardines and 5 things that people really didn't like? That would be a problem. And who wants to eat an entire watermelon in a day? It's very yummy, but it's very high in sugar as well. And if they don't like it, then they're out of luck. So I tell my patients, it is a beautiful thing that there are not 5 magic foods. And as long as you really stay within more of an anti-inflammatory nutrition program, you're going to be optimizing every organ in your body. The other organ that people are particularly fond of and really want to optimize is what? Their brain health. I can't think of a single person who doesn't want to optimize their brain health. And especially in our patient population, these men and women, they want to be productive until the day they die. And so it's really, sometimes I'm giving these recommendations. I'm saying you really need to be tested for sleep apnea because you're telling me that you have brain fog. So even outside of the ED you're seeing me for, your brain needs oxygen at night, and it does not require a rocket scientist to tell me that oxygen for the brain is important. And yeah, so I just try to simplify the nutrition. I'm not getting into the weeds, and I don't think that anyone listening to this podcast has to get into the weeds. If you have a handout, You have someone on YouTube, you get my sister's BiteMD that has all these curated healthy options. Maybe it's 3 resources you provide your patients, and that is good.
Dr. Amy, though, how do you use technology for people to do their own experiments with the wearables?
Oh, yeah. So I like to use wearables in my office as well. There's a technology by FirmTech, and I use their tech ring. Full disclosure, I am on their scientific advisory board, but it's a smart cock ring. And so if my patients want to determine what are the foods that they're eating that will optimize their erectile health, I tell them, I will never be able to answer that question for you. So why don't you figure that out and you can track it? You cannot hack what you don't track. This is also a saying I like that Dr. Elliott came up with. So you could be eating your normal nutrition, track your nighttime erectile function, change up your nutrition, and see what happens. People ask me, what is the impact of gummies on erections? What is the impact of alcohol on erections? I know what the research tells me, but I also tell my patients, try it. See what happens with your erections when you drink 3 beers versus 2 beers. And let that be your impetus for potentially changing your habits.
Awesome. Michelle, you wanted to add anything else?
So eventually we will have an application, but right now we just have an online platform with a like a storefront that will populate items into your Amazon cart, along with a lot of nutrition blogs on gut health and weight loss. But really the premise for BiteMD, which I co-founded with my partner who's a gastroenterologist in South Florida, is to really identify triggers for GI symptoms. And then you can expand it to actually other quality of life concerns. So you're able to take a picture of a meal, it identifies the ingredients, and then you can track GI symptoms, heartburn, bloating, diarrhea, and constipation. And then using AI machine learning, it will help you identify to say, okay, it looks like it was the garlic and the seasoning that caused your bloating, and then bring in a whole recommendation engine. How do we give you that similar flavor profile, but not cause you bloating and kind of give you other ingredients to use? And then, really targeting gut health. But I think there's also, a really good utility for then expanding that into, let's say, the urology space, right? So what are the triggers? Is it, let's say, the alcohol or the time that you drank or the number of beers that, caused you to urinate 3 times at night? So lots of applications for that, but all about, harnessing technology to really collect the data and better inform us. Because with a 15-minute clinic visit that most people get, if they're lucky, there's no way you can collect that data and then give people tangible things they can start working on.
Michelle, what's on your storefront, though? Because I think that's a really good resource for people listening.
The address is bytemd.app. And if you go at the top to the store option, you can go under like snacks or meal ingredients or like protein powders. So everything is from Amazon and you can get it in like the little snack pack. So super easy to outfit your office or your home, travel friendly. Most of them don't smell unless you're getting like the anchovies or the tuna. So.
No, because sometimes also, us as physicians, we forget about take care.
We're the
ourselves.
worst.
We're the worst. So definitely all those hints that you're giving, I'm gonna start writing them down. So, Amy, do you any closing statements?
I'd say my closing message is we're all busy and we don't have to be everything for everyone. So if you're lucky enough to partner with someone that's like my sister, I think that's an incredible opportunity to offer holistic, comprehensive care. And if you're in a single, specialty clinic of urology and you still want to at least broach some of these topics, then just find the really good people out there who have really good online content. Put together a piece of paper. It could just be like a 1 piece of paper that just has their social media handles and direct your patients to that content. Everyone deserves that conversation, just like my sister was saying that not every woman's going to be interested in hormone therapy, but every single woman deserves a conversation on hormone health and what her options are. Everyone deserves that 1 pager with the good resources. And that could also include books.
And Michelle, you take telehealth? You do telehealth?
Yeah, I do virtual. My closing remark, which is a little bit off topic from what we've been discussing, is burnout is real. And the physician shortage and healthcare provider, shortage is only getting worse. I went through it. My sister went through it. I woke up super anxious and just at times just didn't want to go to work because I was just so overwhelmed. I think it's only getting worse. We have incredible control as healthcare providers to really advocate for ourselves. So much of the time we feel like we have to follow one path where we can't take time off. We have to go from one job to the next, and our first job is going to be the last job, and it has to be the dream job, and everything has to work out. It's all about building your brand. Build your brand. If you're within an academic institution or a large practice, start building your brand early as a personal brand, not under like an umbrella. So that gives you the option of, if and when you leave, people know who you are and not just you as part of an institution. The other thing would be diversify. What Amy and I have such a blessing of what we're able to do today, which keeps things super exciting, is we're running a business. We are offering, I think, really good top-notch clinical care. We're involved in research. We're writing papers. We are educating and doing outreach and going to community events and, getting feedback from people. That is a beautiful thing, to be able to diversify how you spend each and every day. We had a meeting earlier today and someone said, what are you doing on Wednesday? And I said, every day is different. My goodness, how amazing is that? Because so many people get burned out because every single day becomes the same. And so there are a lot of opportunities with consulting, starting a practice, doing research, again, education, working with students, mentorship. These are ways that I think we can combat at least part of burnout.
Well, thank you both being part of this episode, and thank you for all the dropping the knowledge.
Thank you for having us. Always a pleasure.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.